one and all present here. I welcome you all to this very wonderful evening of No Thrombosis today. We are very proud to announce that No Thrombosis has been chosen to be the best, most engaging scientific platform from any pharma company by the SIMS Healthcare Excellence Award 2021. And we are very proud, privileged, and honored to have very senior faculty members with us. I would first like to welcome our course director, Dr. Shirish M.S. Hiremat sir. Sir is the director of Cath Lab, Ruby Hall, Pune, India. Sir is the president of CSI 2017. Sir is also the program chair of CSI Conference 2016. Sir has been the convener of National Intervention Council of India from 2004 to 2006. Sir has taken many live angioplasty courses for many national and global intervention conferences. Sir holds great experience in peripheral angioplasty, including legs, carotid, and iliacs, and has also participated in some groundbreaking trials. I would now welcome our moderators to the session. Our first moderator is Dr. Jabir Abdullah Kuti. Dr. Jabir is a senior consultant and director of clinical research at Lisi Hospital, Cochin. Sir brings with himself over 2 decades of cardiology experience. Sir is a well-recognized cardiology and a faculty in many national and international conferences. Sir is expert in managing complex heart diseases, and his main area of interest lies in coronary interventions and heart failure. Our next moderator for the program is Dr. A. Srinivas Kumar sir. Sir is a director of cardiology and clinical research at Apollo Hospitals, Apollo Health City, and also the professor of medicine at Apollo IMSR, Jubilee Hills, Hyderabad. Sir is the chairman of Facts Foundation and FPS, and also the founder director of TCT India, the South Asia Conference. Sir's special interest lies in TAVI, intracoronary imaging, OPCI. Sir has also been the past president of APCSI and past chairman of CSI NIC. I would now welcome our guest moderator, Dr. Sameer Dani, to the program. Dr. Sameer is a chief cardiologist at Apollo CVH of Heart Institute, Ahmedabad, and also the director of cardiology services at Apollo Hospital, Gandhinagar. Sir has been an honorable cardiologist to HE, the governor of Gujarat, and also the former professor and chief department of cardiology at UN Mehta Institute of Cardiology at Research Center, Ahmedabad. I would now welcome our 2 key speakers for the session. Our first speaker today is Dr. Gaurav Verma. Dr. Gaurav Verma is an intervention cardiologist at SMBT Hospital, Nashik, and Tame Hospital, Sangamner. Dr. Gaurav Verma would be presenting an interesting case on complication during LM angioplasty, how I managed. Our second speaker for today is Dr. Ankit Dedia. Dr. Dedia is a consultant intervention cardiologist at multiple hospitals in Mumbai, including the Holy Family Hospital and Hinduja Healthcare Hospital, Mumbai. He will be presenting an interesting case on a calcified lesion. I would now I once again welcome everyone to this wonderful evening, and it is indeed heartening to know that No Thrombosis has garnered national interest, and we have faculty members like Dr. Hiremat sir and Dr. Srinivas sir, Dr. Jabir sir, and Dr. Sameer Dani sir joining us for the program, and eminent speakers like Dr. Verma and Dr. Dedia with us. I would now request Dr. Hiremat sir to give us an overview of the program.
Good evening, sir.
Yeah.
Thank you and good evening, everybody. You heard from Dr. Neha the progress which No Thrombosis has made, and we had a big meeting last time to celebrate the 25th presentation. So today we are back to you, Gaurav.
Sir, good evening, sir.
Good evening. And Gaurav had a very nice 2 sessions in first 25, isn't it, Gaurav?
Thank you, sir.
Yes. We all are expecting a lot more from you today compared to your previous presentation. So over to you, Gaurav. You're talking on left main.
Yes, sir. Thank you, sir. And it's always delightful to be
Dr. Gaurav. 1 minute, sir. Just we from this program we have decided to have a guest moderator also. Dr. Sameer Dani sir has also joined as a guest moderator. So he will be accompanying with you and Dr. Srinivas Kumar sir and Jabir sir to discuss this case, and he will present his small talk as well at the end, sir.
So Samir, you take the third slot.
No, I'm supposed to be the guest moderator, so I guess I'll listen to I don't think I have any slides.
Okay,
I'll be just discussing the case with Dr. Srinivas and Dr. Jabir.
Okay, today we'll take a back seat. Dr. Kuti and Dr. Srinivas, and Samir, you have the stage for you. Okay, let's go to Gaurav. Gaurav, over to you for your presentation.
So first of all, sir, always a pleasure to be with you, to hear from you. Your comments are always, are very valuable to me. And I have been always a follower of your techniques, your whatever you say, we just follow blindly because we believe in you. And I just also want to give my greetings to our other moderators, Dr. Srinivas sir and Dr. Dani sir. And I'll proceed with my case, which is about complication which happened during my left main stenting, and I because of the program highlight, I wanted to share something which has to deal with the thrombus formation during that procedure. So can you see my slide now?
Yes, it's loading. Yes, we can see.
So I'll begin with my case. So the history goes like the patient is a 70-year-old male. He presented with acute coronary syndrome for last 5 days, and there was some EC changes in inferior lateral leads, and the ejection fraction was around 45%. He had a significant past history of undergoing angioplasty to circumflex 2 years back in 2019. And at that time, RCA was CTO and was managed medically that time. And that time also the ejection fraction was 45%. So in 2 years, the patient was doing okay. But since last 5 days, he was symptomatic in terms of progressive angina, and he was quite symptomatic with some minimal exertion as well. So just to show the diagrammatic representation of what has happened before, the RCA was CTO that time, and that time in the proximal circ, they had put a stent. And this was the history for last 2 years till 5 days back. And this time he has a new onset angina, which was progressive in nature, but the EF was similar to last time, what was 45%. So after giving heparin and managing him medically, we took him for angio. And just to have a representation before I go to angio film, this was the diagram before what he had 2 years back. And this time we could find a distal LM disease with a significant LAD, as well as ostial circumflex disease extending up to the stent as well. Along with that, there is a diagonal disease also, and diagonal was a big vessel which required intervention as well. So let us see the angio. This was the angio in the allocaudal view. You can see there's a tight stenosis in the distal left main extending to LAD ostium as well as circumflex ostium. This is the epicaudal view. We can see the retrograding RCA and a stent in the proximal part of the circumflex, and a tight lesion in the carina of left main as well as the LAD and the circostium. The cranial view showed a significant disease in the diagonal as well. We can see the good size diagonal, almost similar to the size of LAD, and there is a mid tight lesion, and which I thought that also requires intervention. So this was the scenario with us, and now the patient has a distal left main. Always the option of bypass was given, but due to the reluctance for surgery, they opted for angioplasty. So what we thought that because of the disease, severe Medina class 111, we thought that we'll manage with the two stent strategy. First, because of the tightness of the disease in the circumflex, we'll manage one stent in circumflex. Then we'll do a two stent strategy into LAD, and finally we'll tackle the diagonal. This was the plan to begin with. So we thought that we'll do a decay crush to LAD circ left main, and then stent to diagonal, and RCA we kept to tackle in next sitting because the culprit lesion we thought was the new disease in the distal left main. So as planned, we started with a pilot 50 wire for circumflex. So the wire went easily. Then we did a small balloon dilatation with a 1.50 balloon, followed by a sequential dilatations with a 2 balloon, both from the mid segment of circumflex to ostial circumflex, and also dilated some part of the left main as well. Then, as per the decay crush strategy, we took a 3.50 balloon into the LAD and a long stent from the left main till the distal edge of the disease into the circumflex. Dilated the stent, followed by a half crush, what some people do, followed by the crushing of the circumflex stent, and everything was fine till this moment. After that, we recrossed with a smaller balloon, then to a balloon, then did a first kiss. But after this, something unexpected happened, and that was that there was a big thrombus formation inside the LAD artery, both in the proximal LAD, ostial LAD, as well as the diagonal just got closed off. So after crushing with the first case, after the first case, there was a thrombus formation proximal and the ostial LAD in the mid LAD, as well as the diagonal just closed off. There was a drop in blood pressure. Patient had severe angina at that time. We had to call anesthetic, give him some sedative, and then after giving some vasopressors, we tried to cross the diagonal. Crossed it, then did a daughtering, but flow didn't come the flow was not that much restored. Then we have to do a 2 balloon dilatation. After that, there was some flow inside the diagonal, but still the flow was not that great. So at this moment, we thought that we'll do a stenting to diagonal at this moment, wherever the healthy zone and as well the angio was showing the disease. So we stented the proximal found some flow restored inside the diagonal, and LAD was flowing, and there was some thrombus inside the LAD as well. So we thought that first we should complete the dissected area where in the proximal as well as the ostial LAD, and we went ahead with doing the remaining part of the decay crush. We did a 3.50 into a 28 millimeter stent, dilated it, did a pot, recrossed it, did a final kissing, did a pot again, and we ended up with this kind of flow. So at this moment, we thought that still there was a less flow inside the diagonal. So we thought that we'll stent that portion also, because we can find some thrombus in the distal part of the diagonal as well. So we took a small stent and dilated that as well. And this was the final result what we got. So we didn't do much here and ended it here only, watching the patient throughout the night, and kept him for 2 days again in the hospital just for watch. Didn't take a shoot again, and patient is doing well now. So the question which arose of this was that why the thrombus was formed, and is only what I did, the stenting to the thrombus, was the answer. Do we have thrombosuction also to our rescue to this kind of thrombus in emergency situation? And third, again, as per the talk for today, like no thrombosis, what would be the therapy or the strategy of our experts about rivaroxaban and warfarin, or they will just try to continue with the dual antiplatelet in this kind of setting? So I'll stop short here and I'll be happy to listen to the comments.
So let's invite Dr. Samir to have some comments on the way the case went. Dr. Samir?
Yeah. Hi. Great case, Dr. Gaurav. And well, the question is why the thrombus formed, and what could you have, or what could we have done to prevent this, or what measures we should take to prevent this thrombus. This guide was 6 French?
7, sir.
7 French. All right. So whenever you do bifurcation stenting, and whenever we do especially decay crush, and when we keep 2 balloons inside, the chances of thrombus formation inside the guide are always higher. And so we generally, we take 7 French guiding catheter rather than 6 French when we are doing left main, and when we are doing final kissing balloon 2-stent strategy especially. Or even when we expect 2 stents strategy to take place. So that is one thing. Second thing is that we generally beforehand try to get the ACT to 350, at least above 300 in these cases when we begin the cases, when we begin balloon inflation or stenting. And we repeatedly check the timing. Like when you take the 2 stents or 2 balloons inside, how long you are keeping your balloon inside. You part the balloon in LED, then you dilate the circ, and you put the stent in the circumflex. All this should be kind of timed so that you are constantly aware that you are not exceeding your time limits. And of course, it also helps, especially in these ACS patients, to load them properly. Make sure that you have loaded them with ticagrelor, sufficient dose, and aspirin has been given on the day of angioplasty or not. So these are the few things. And of course, once the thrombus is formed, you have to take the ACT up, and you may have to use the P2B3A inhibitor, and you have to take care of the stent thrombus by stenting and excluding the thrombus from the lumen. These are the vital things which you did so very nicely and pretty rapidly. And then, of course, if you have any imaging equipment like IVUS or OCT, that would also help. Not beforehand, but after, especially after doing the stenting, make sure that your stent is well expanded and your thrombus.
Submit the dose of heparin. How do you do? I mean, what we routinely do in every case, thrombus or otherwise, is 5,000 bolus, and then we check ACT at say about 20 to 25 minutes, and try and keep ACT close to 300, or sometimes above 300 if we feel there is a thrombus. So what is your strategy? I mean, whatever weight, whatever patient's status, this is our standard protocol. So how do you do it?
Our protocol, generally we are like 95% of the cases are radial. So even when we use 7 French, so whenever we are doing radial case, we just give 10,000 flat, 10,000 units of heparin, and then check ACT. And generally try immediately after 5 minutes.
What is the idea in checking? I mean, you almost if you're
in such cases. No, in such cases where we want the ACT to be above 300, close to 350 when we are doing the angioplasty. When we expect is ACS, or when there is a bifurcation stenting, then when we check ACT after 5 minutes, we make sure that we are at that level. And then we recheck the ACT depending upon the complexity of the case, either at 30 minutes or 60 minutes. If the case is femoral, then we give 7,000 or 7,500 and then check. If the case is fairly simple, then many times we just give a radial case, we give 10,000 flat heparin. We do not even check the ACT, finish the case, and if the case is getting prolonged, that at the end of 45 minutes, we check the ACT. If the ACT is checked or not checked, it is invariably checked at the time of closure. Before removing the sheets, again the ACT is checked, and we make sure that at the time of closure, the ACT is close to is at least 250.
I think for us, at the time of sheath removal, we expect the ACT to be 180 or less. If it is something like 220, we would wait for a little longer, maybe half hour, and probably check ACT again after half an hour, and then remove the sheet. So 180 is our cutout point when we remove the sheet.
For femoral or radial?
No, we are talking of femoral. I was coming to that. For radial, it's a totally different story. So many times we don't even check the ACT. Our first bolus is about 5,000, occasionally 7,000 if the patient is overweight. And at the end of radial procedure, we remove on table itself.
So generally, it is 100 units per kg now. Sir, we tend to give a minimum of 7.5. If patient is obese, we could go up to 10. But generally, heparin recommendation is 100 units per kg. So we should give at least 7,500 we feel, because many patients are about 60, 70, then 6,000, 7,000 may be okay. 5,000 may be slightly less if average patient weight is like 60, 65. But many of the times if procedures are finished faster, it doesn't matter. But such complicated cases, I think left main, which are likely to take longer, I think it is better to give little higher dose.
Yes, Dr. Srinivas, I also fully agree with you. When you do a bifurcation, not only bifurcation, he has to go and stent the diagonal, then come back, and it's a complex, it's a DK crush, which takes time. But two recrossing, then two kissing, then followed by a port, and then report, and all. It takes time. And you are manipulating the left main, manipulating all the vessels. I think it's better to keep the ACT somewhere around 350. As you said, the standard we use is 100 units per kilogram body weight. Then we take the ACT at a time span of half an hour or 1 hour and substitute if required, especially if it's a long procedure.
Sir, of late, what has happened, earlier we were doing the same, like 100 units per kg, but like sir said, Hiramat sir said, we start with 5,000 and after probably half an hour, we check ACT and then we repeat it. We don't give bolus fully because we had sometimes hematoma, sometimes other complications. So it's always a safe bet to start with a low dose and then you load it. So, and we usually...
Let's check with these three experts today. I think all of them are using radial as their first approach. And as Samir mentioned, maybe about 5% or 10% cases are from groin. So do you make a difference when you're going from radial and when you're going for groin about the dose of heparin?
Yes.
It definitely allows you more liberty to give a bigger dose when you're going through radial. So your radial dosage, Samir, is bigger than the...
Oh, yes, absolutely. My radial dose is like what we have found, as Srinivas said, we used to give 100 units per kg. And then we found that many of these cases would not reach beyond 250 or 280 when you give 100 units per kg. So in these cases where the complex cases where we want ACT to be higher, we just go flat 10,000, recheck after 5 minutes that ACT has reached 350, and then while doing the procedure. If it is femoral, I definitely reduce my dose by 25%. I don't go beyond 7,500 as an initial bolus. I do 5,000. But I always recheck. When I give 5,000, I check my ACT 5 minutes into the procedure. somebody will check it. So that when I'm doing the angioplasty, while I'm doing bifurcation or something, I want my ACT to be 300 plus.
All right. I think lots of discussion on ACT. What about this case, Dr. Srinivas?
The other reason, apart from all the things which we need to check, which Dr. Samir already mentioned about ACT and giving proper dose of dual antiplatelets and probably treating them with the heparin and guide catheter flushing, all of the precautions are to be appreciated. But whenever you are finding a Gaurav, it must have happened, like you must have also done like that. But if you're planning to work on diagonal, it is better to wire the diagonal before it gets occluded. And whatever we do, suppose many of the times we may not do anything also, but wiring is not a problem. So we would have wired the diagonal before landing it. Closure, luckily it opened up, but sometimes it could create trouble. So
sir, in this case, you would have taken 3 wires, is it?
Yeah, probably we can. There's no problem. That is one. And the second thing is,
since we are on this point, would you stent diagonal first, complete job on diagonal, and then come to left main?
Yes. Suppose unless the left main or the proximal lesions are very critical, where the flow itself is getting less and patient starts getting into angina, things like that, always preferable, especially when you have such long lesion. LED, like finally you ended up putting a longer stent in the diagonal. It looks like it was very large vessel. So it's better to finish off the distal job, though latest generation stents do track from stents to stent like it happened here. Sometimes it could create trouble. So if it does the planned before, as you said, probably you could treat it and complete it before you get into trouble. But only exception I would feel is if the proximal left main is very critical or proximal LED is very critical, where wiring itself is leading to ischemia, things like that. Even then you can just balloon dilate and finish the distal stent work and then come back to the proximal. But generally, we prefer to finish the distal work and then come to proximal. Other reason for clot formation, what do you think? There is a dissection there, Gaurav. What do you think? Dissection plus thrombus? Sometimes that could also happen, no? There is no separate reason for clotting like other general causes. But if the vessel dissects there could be some clotting developing there. It looked to me that it was dissection because of high pressure inflations of balloon, and then probably associated with it some clot started forming. That's also a possibility.
Dr. Srinivas, talking about your first part, in this particular case, if we work on the left main, we are very likely to cover the ostium of the left main. I think that is a standard technique, especially for short mains, short left mains. And then to get a second stent in when you have a stent at the ostium, sometimes it's a challenge and very unnecessary.
Very unnecessary.
So I would probably feel that whenever you have such a situation, if your left main area is very critical, do pre-dilatation to that area. But take your stents to the distality, like in this case, the diagonal. Finish up that so that you can focus on left main bifurcation. All right.
Another aspect, what we need to be careful, Gaurav, maybe you have checked, is what stent you are taking, because each stent has expansion limits. Suppose you have taken only 2.5, 2.75 stent for the LCX. It is projecting onto the left main, and you are planning to proximally dilate with a bigger balloon. The maximum expansion limits of each stent, I think it's there on the display of the box. We need to keep that in mind. Suppose you take 2.5, you can't expand it to bigger sizes in left main. I think if you take 3, it is okay. It can go up to higher sizes. But sometimes if LCX is needing only 2.5, 2.75, it may not go up to 3.5 plus sizes what you like in the left main. So that is another important thing which we need to keep it in mind. Though later generation stents expand differentially. Like you have a Resolute Onyx, I think even from the 3 plus platforms onwards, it can go up to 4.5. But it may not be the same with all the stents. So you need to keep that in mind, the maximum diameter which the stent can expand. Otherwise, distally, it tends to get distorted.
By and large, all the stents expands by more than 1 centimeter. So,
but Jabir, 2.5 cannot go to 4.
No, 3.5. 3.5. But higher, but bigger stents, they can go up to 5 and some up to 5.5. The 3.5 of the Onyx can go up to 5.5. The Zions also go up to 5.
Yeah.
I think we must know how many connectors are there along the length. And more connectors, your expansion limit is limited. If you have fewer connectors, you can go up quite well in left main. So 3, 5 stent could be stretched to almost 5 in the left main.
Dr. Deman, do you think there is some mechanical reason for thrombus formation? But following which his procedure was so smooth, there was no difficulty in passing the balloons or then tracking the stent. Otherwise, one thing is crowding of the, it's all happened after the first kiss. So inadequate crush is one thing that may produce the stent, some of the stents crowding around the ostium of the circumflex, which can which may stimulate a thrombus formation. But the rest of the procedure, when we look at the rest of the procedure, it was so smooth sailing, so unlikely for a inadequate crush.
Gaurav, you want to answer this? Because
Sir, what we analyzed later, there were two things which came to our mind. One was what Dr. Dani said about the heparin issue, that maybe we didn't check ACT at the beginning. And other thing was the milieu was ACS, so probably it was a prothrombotic state. And when the balloon inflation was there, the first case, there was prolonged time for that dilatation that led to thrombus formation. I don't think that some like other mechanical issues were there, because it was likely some unexpected thing which has happened. So probably heparin was. We need to check it more frequently when we are doing such complicated things, and probably the milieu is more important.
And heparin is totally an unpredictable drug. The action is unpredictable.
No, Dr. Samir, I would feel once you give heparin, whether you give 5,000, 7,000, 10,000, I would expect action on, definitely on immediately. So I would probably skip doing 5 minutes ACT, and I mean, it's a waste of time and effort and money probably, and do a repeat ACT around 20 to 25 minutes, and then decide whether you want to give a small dose like 2,000 or you want to give a bigger dose like 3 plus 1,000 in the because the ACT is less than 300. So I would probably feel the 5 minutes ACT, I'm not very, I mean, I feel it's not necessary. I mean, that's your style. But
I agree. I agree for most of the cases, but especially in complex cases, as Dr. Jabir said, this is heparin is #1 unpredictable drug, because it does the potency varies from batch to batch, even in the same company. So it's always safer when you want surely that your ACT should be 300 when you are doing the procedure, and especially when you have a procedure like this, when you are doing left main bifurcation, your whole focus is on the case, and 20-25 minutes later you are already deep into the case. You are doing first kissing, and you are delivering the
you are doing ACT check at 5 minutes for all cases, which I feel
not all cases. Not complex cases. Not all cases. I agree with you. Not all cases, because in most of the cases,
I mean, we expect that once you give a bolus of 7,000 or 10,000, the ACT would be nearing 350 within 5 minutes, almost always. I mean,
if you are 10,000, I can tell you that after adopting the policy of giving 10,000 from radial, whenever we are doing radial, we give 10,000 without any blink of an eye. Then most of the cases, the ACT is between 300 to 350. Most means 95% of the cases. It's rare to have a case where your ACT is below 300 after 10,000 units. So there, yes, sometimes we feel that, okay, let's do the 5 minute, but we are sure that we have given 10,000 units separate. But if you are giving 5,000, I would definitely check ACT at 5 minutes before doing a complex case.
Now, whenever we listen to these complex cases presentation, and something has gone wrong, many times it's the bleeding which actually worries everybody, and the cause for bleeding could be mostly apparent. So I would probably feel you give a small dose more time. Probably you and I end up with same amount of heparin at the end of procedure. However, I'm splitting it into small multiple boluses and probably looking at the ACT. This is how I think you can avoid, like sometimes you expect your procedure to go for 45 minutes, but somebody like you can finish in 5-10 minutes. If your fellow is doing it, you'll probably go 45 minutes. So I think this difference should be kept in mind when you are doing a case of this nature.
I beg to differ here on just one point. If you are starting with lower dose, check it. It's more important. If you are starting with bigger dose, 10,000 heparin, yes, you are sure that your ACT is 300. And then if you are radial, you are not bothered about the bleeding that much with 10,000. But if you are starting with 5,000, especially in a complex case, please check ACT. Somebody else can do it. While you are doing the case, it's a system. Somebody can check the ACT 5 minutes after giving heparin, and you are sure. If 5,000 heparin and your ACT is 180 and you are doing left main, you are likely to be in trouble.
Dr. Srinivas and Dr. Dani may be remembering when we all started doing angioplasty, it was blanket 10,000. There was no ACT checking and all. 10,000 to begin with, 10,000 heparin blanket, and then we start the procedure. That time we didn't have this much powerful antiplatelets.
Right. I think let us end with the consensus of 7,500 is in between and then proceed further because I already finished 35 minutes.
You reminded us of that. Okay.
We'll go to the next case.
Sir, just one query more. Regarding the post-discharge treatment strategy, do we require to give rivaroxaban?
No, this is only procedure related. No, why do you need to give all that?
Because of some thrombus remaining inside, sir.
You create something and later on you can't blame the patient. Suppose before it was a problem.
I'm talking about the thrombus which is still there. It was there.
This is the thrombus. You might give GP2B3 receptor blockers or something immediately till it lyses totally. But I don't think, suppose there's ectatic vessels with large thrombus burden, that's where I think sometimes we tend to give NOACs or something long term, but not with dual antiplatelet. Dual antiplatelets, again, with a NOAC, it's again a more bleeding tendency. Then you need to stop aspirin and give NOAC and one of the lower potent antiplatelet like clopidogrel. If you are giving even with Ticaplat and prasugrel with the NOAC, we are again worried about bleeding, especially elderly patients like yours, 72 years. Always we tend to not to give 3 drugs together.
Do you give low molecular weight heparin for a longer time? Like normally, so many times we don't even use low molecular weight heparin. Sometimes we give it for 2 dosages, one immediately at the end of the procedure, one next morning, and then you discharge the patient. While this kind of case, I would probably feel that LMWH for about 5 days in hospital or partly after going home would be an important addition. Of course, with the NOACs, the role of LMWH is taken over by NOAC, so you could safely give NOACs too.
Sir, what I was thinking, like you said, that with ticagrelor, rivaroxaban low dose 2.5 BD, that gives you more some support that okay, we are giving anticoagulant also, because residual thrombus do have a tendency to attract more thrombosis, isn't it?
No. If you want to give a good dose, I don't think 2.5 twice a day is a preventive dose. I mean, for a thrombus which has already formed. So you're talking of some thrombus which has moved into the branches and things like that, and you want to take care of this. So you need to give a standard dose.
Or sometimes you discharge with low molecular weight heparin, as sir said, for 3 days or so, and then later on continue dual antiplatelet.
Right.
We will proceed.
Thank you, sir.
Thank you,
Thank
sir.
you, Gaurav. It was a very exciting case. We all learned a lot. We now move to second case. Dr. Dedia from Mumbai.
Yeah, good evening, everyone, to all my bosses, and quite a heavy discussion we had, and I'm happy to be a part of getting so much valuable inputs. Can you see my slides?
No, yes.
Yeah, so sorry. I am going to present a case which is not related to thrombus, but this patient came to me recently, and there was a debate because my physician was against putting. There was a discussion between me and my physician friend whether to put this patient on rivaroxaban or not. So to begin with the case, without wasting time, this was a calcified lesion, PCI done with the help of OCT imaging and IVL. So my patient was a 65-year-old gentleman, hypertensive, non-diabetic, had increasing angina. Patient had, in the last few days before the procedure, patient also had rest angina with almost class 3, class 4 angina. LVEF was normal, renal function was normal. So this was the angiogram. RCA was normal, dominant RCA. So I've not posted the video of RCA. This was the LAD, left system. So if you can see in the left side of the in the moving video, there's a, before the dye is injected, there's a chunk of calcium in the LAD. So we decided that yes, patient also has a circumflex lesion around 75-80%. So first we tackled the circumflex with a simple pre-dilatation and stent and post dilatation. I'll just. So if you can see the third image, moving image, we got a good result in the circumflex. Following that, we decided to do a OCT run for the pullback for the LAD. So this was the LAD pullback. If you can see at the 10 millimeter marker, that would be the reference diameter for us. Of course, I'll give you the details. Then while we were coming back at around 25 millimeter marker, there was so there is a lot of calcium here, and it persists almost for more than 5 millimeters. Yeah, almost circumferential calcium throughout and heavy chunks. So this was the distal reference diameter. This was the tightest portion with circumferential calcium, where more than 2 quadrants, more than 180-degree arc was involved with calcium, and the area was 3.3 millimeter square. Here we had an eccentric calcium 2, and again here. So almost 10 to 12 millimeters of calcium chunk was throughout there, and this was the proximal diameter. So of course we all know that with low calcium burden, the lipid-rich plaque and the fibrotic plaque, we prefer pre and post dilatation with semi-compliant balloon or NC balloon. As the calcium increases, higher the calcium burden, we shift to a rotational atherectomy, or now recently we have shifted to a high calcium burden can be managed with IVL. So to define whether my patient deserved an IVL balloon, there's a scoring system for OCT based calcium score where yes, maximum calcium angle for my patient was more than 180, so he received 2 points for that. Calcium thickness more than 5 millimeters, yes, more than 0.5 millimeters, so he received 1 point for that. And the length of calcium involved in the lesion was more than 5 millimeters. So again, patient received 4 out of 4, which is the maximum score that a patient can get for calcium or based on OCT scoring. So we decided to do a 3.5 by 12 millimeter IVL for this patient from mid LAD to proximal LAD right at the ostium. We gave 8 pulses of 10 seconds each, and from mid to proximal LAD. Following the IVL, we did another pullback. So I'm just skipping this run and would like to show the pre and post IVL images. You can see this was the pre IVL image versus this post IVL image, where you can see the lesion has the calcium has been cracked very well at various sites. Again, even here there was a proper cracking of the calcium. If you can see here at the 2 o'clock position, and this was a large crack that we got near 9 to 11 o'clock position. So our IVL, we thought that the post IVL we achieved a good calcium breakage, and we decided to go ahead with the stenting. We put a 3.5 millimeters by 33 millimeter Zions expedition from the ostium to the mid LED lesion. We post dilated the lesion with 3.5 NC, and the proximal struts of the LED stent was post dilated with 4 by 8 NC track balloon. Following which, again, we did a pullback, and this was the this was the diameter in the distal end. If you can see 6.84 millimeters in the mid LED lesion, in the mid LED territory, 7.4 millimeters square. And here, just at the ostium, we got a 10.28 millimeter square. We got a few red marks on the OCT here. So we went back and we did a high pressure post dilatation with the same 4.0 by 8 NC track balloon. And following that, we accepted the final result, which was pretty decent. And that was it. Just a few pointers I felt I should just brush upon. That all we prefer at our center at Holy Family, we prefer transradial approach unless not possible, or rather wherever we can do a transradial approach, we prefer transradial. We are using more and more glide sheets slender 7F when we are doing a complex case, because that can accommodate more than that can accommodate the hardware well. This always allows me to use any hardware I want, that is rotablator, large size cutting balloon, bifurcation stenting, double balloon, two-stent strategy, imaging devices, and thromboaspiration catheters. Guide catheter support is a must. Never hesitate to use amplats, because many of my colleagues are very scared of using amplats, the younger colleagues. So amplats gives us good guide support. Wherever possible, wherever needed, we should do a physiological assessment, choose the guide wire. Buddy wire technique should never be forgotten. Using anchoring balloon or mother-child technique using Guidezilla has always helped us. And lastly, a proper team approach should be always considered. And whenever we are considering a bifurcation stenting, provisional first should always be considered. When it's a classical Medina 111 lesion, yes, you can plan a two-stent strategy, but provisional stenting is always more. I would say we have reaped more benefits out of provisional stenting. If we are a two-stent strategy as a bailout, yes, we have used, but we generally prefer provisional stenting. Thank you.
Thank you, Dr. Ankit. Samir, again, over to you. You're our guest. And
so my Samir sir, before you start, this patient was done almost 17 months back, and in almost just before COVID, and 18 months back. And patient came to us. Patient was on ticagrelor. Now I had put this patient on a rivaroxaban 2.5 milligram BID. Now patient is diabetic as well, and we shifted from ticagrelor to rivaroxaban 2.5 BID and ecosprin. So the physician called me up saying that why does she need rivaroxaban? He requires a rivaroxaban. Should we not continue only clopidogrel, if at all? So then I had to explain him that I think that this patient deserves a rivaroxaban for because he has got multiple stents. Plus, he's diabetic now, hypertensive, and the stent length is almost more than 40-50 millimeters. So that was my doubt. Okay, was I right in selecting this patient for rivaroxaban or not?
That's a very interesting. About the case, I don't think I have to say much, especially when we are talking about thrombus. You did all the right things. You opened up the you did the imaging. You opened up the lesion with IVL, proper technique. You expanded the stent well. You made sure that the stent was well expanded. So I have no real comments on that technique part. But yeah, so my question would have been that in this case, what would be your integrated strategy? Nowadays, unless the patient has a high bleeding risk, we always use ticagrelor or 90% of our cases are still done with ticagrelor in spite of ticagrelor controversy. So these are the patients who are on ticagrelor and aspirin, and we generally continue for 1 year with ticagrelor and aspirin. Sometimes in those patients who have any problem of either bleeding or caused, then we switch from ticagrelor to clopidogrel at the end of 3 months. And now, I mean, that strategy did not have much validity up until now, where now you have a Korean study which tells us that switching from ticagrelor to clopidogrel after initial 1 to 3 months is a good strategy, and there is no problem with that. So we have data for that. Now, the question which you say asked, that changing from DAPT to DPI at the end of 6 months, when should we do that, if at all we do that? Most of the data is for after 1 year. When you have index event, index ACS, 1 year prior, then in case of these high-risk cases like multiple stents and thrombotic tendencies, you switch over from DAPT to DPI. That makes a lot of sense. Whether you can do that earlier or not, we don't have enough data. But why did you do it? You felt that DPI would be a better choice than DAPT with ticagrelor?
No, sir. The patient continued. Actually, patient did not come at 1 year interval. Procedure was done almost 18 months back. Patient has taken ticagrelor for 18 months. Okay. Now, when I switched, I told that you have taken ticagrelor. No, 18 months. Ticagrelor patient has taken 18 months. So I told them that you have taken it much longer duration. So we have to stop ticagrelor. When I was switching from ticagrelor, I considered to add rivaroxaban for this patient. So my physician friend said, "Okay, not needed. 66-year-old. Why you want to, elderly? Why you want?" So there was a kind of a debate. So today we are discussing no thrombus. Of course, my case is not having thrombotic issues, but I thought that this was whether I did the right thing of adding a rivaroxaban for such a patient.
Well, to my personal opinion, yes, I would do the same thing. And someone who is not very high bleeding risk, but he is having high ischemic risk, and his index event or ACS event has been more than 1 year prior, I would think of switching over from DAPT to DPI.
When you make a switch at the end of 1 year, you're obviously not worried about the stents which have already been placed. You're worried about other areas which are not covered by stents. And this takes us to the COMPASS data. And COMPASS data is like this, that after 1 year, what to do. And there it is supporting your a thought, Dr. Dedia, that you can switch to rivaroxaban 2.5 twice.
And only one more question is, now immediately when we start our patients on such a drug, the relative has to ask how long this has to be continued. So in such,
why the cost?
How long? Not for the cost, but when we are explaining them that rivaroxaban is is an anticoagulant, it's not like a routine antiplatelet drug. So we have to be a little bit careful. So while priming our patients, they ask then, why are we putting this drug? How long is it to be taken? So the duration is another big question mark for me. How long should we continue this drug? Like rivaroxaban, as per the compass data or the recent trials, there is no duration like how we have for ticagrelol, that we have to give ticagrelol for 1 year post angioplasty. So that rivaroxaban doses as yet. So this question is always. I
strongly feel that if you're adding ticagrelol to DAPT, I would take away aspirin. I think if you have all three going, I think the bleeding possibility clearly increases. And we have enough data to indicate that ticagrelol alone, without aspirin, aspirin stopped at 1 month as well as 3 months, is good enough to take the patient through the stenting procedure. So I would probably feel that 3 together is probably too much. Though, of course, your dose of rivaroxaban is very, very small, 2.5 twice.
No, sir, not 3 together.
I think, sir, can I take
I was saying now patient is off ticagrelol.
Ankit, actually, we need to be clear, and a lot of colleagues and doctors are listening. So there are 2 aspects of this NOACs. One is you shouldn't get confused between the acute usage of low-molecular heparin or acetylene for that matter, or other acute thrombotic, where if you have to use it, use full dose. Like what Hiramat sir said, there's no point using 2.5 mg PD when you suspect a thrombotic burden there, something there left in the coronaries. You use proper dose. Probably take away aspirin, use only 2 drugs. One of it can be full dose Novax. That is the acute stage where you are bothered about thrombus. The other scenario, what we're discussing is DPI.
Dr. Srinivas, this 2.5 twice was
the DPI. I'm coming to that, sir. In chronic scenarios, once you finished 1 year, where that is a compass trial data like polyvascular disease, where all you find risk is higher, 2.5 milligrams BD is supposed to be having a different mechanism of action, preventing the recurrent events. It is not increasing the bleeding there. So we need not worry. So we always, all of us have a worry of Novax causing bleeding, but that microdose 2.5 milligrams BD is the one which struck the balance where the bleeding risk did not increase. But because of the DPI, the other mechanism of action, the occurrence of secondary events increased, especially strokes. It really mattered. So that why you are giving 2.5 milligrams BD is for that benefit, not for
antithrombotic. We have to make it clear at this stage. Yeah. This 2.5 twice a day is not for the stent that you put today.
Yes.
It is for 1 year later.
That's what I'm saying.
We want the benefit to come.
Yes.
And that's why people who have finished 1 year, I think you can use it. And that is not for today's stent. It is for future events which might come from areas which are not stented. Yes. Areas where you have some kind of plaques today which might rupture at a later date. And that is a preventive sort of strategy.
I think Emcure is doing that Emcure study, sir, in which collecting data with this 2.5 milligrams BD of rivaroxaban in chronic stable angina and patients who not in acute stage. But one thing I should appreciate, Ankit, is you have shown that is how OCT gives very interesting pictures. And pre-post, you have shown excellently. Even the novice can understand how the calcium gets cracked and how it is beautifully shown in by the OCT. I did not understand what was it you did in LCX, but anyway, I think there was a lesion which you must have dilated and put a stent. But LAD, how you tackled is shown very well, and the OCT pictures were very good. Thanks for showing.
I would have felt that this circumflex needed something like FFR
Yeah, I was not sure about the lesion.
Yeah,
That's what I was mentioning.
But anyway, I mean, FFR, no FFR, this discussion will continue, and probably many times, just to save time also, people say go ahead and stent. To save a repeat cost to the patient, people say go ahead and stent. We are, of course, buying a possibility of ISR. However, I think today's stent ISR possibility has gone down substantially.
To answer your question, Ankit, how long to continue with rivaroxaban aspirin dose in these kind of CCS patients where you perceive them to be high risk? COMPASS data out to 3 years showed that the curves were still diverging. So up to 3 years, you still have ongoing benefit. We have data to that extent. So I would say it will be a long-term strategy. Put them on DPI if they can afford it, and if their bleeding risk does not increase. Sometimes when things change, it's dynamic. So, but otherwise, the curves continue to diverge. As you give rivaroxaban more and more for longer time, the bleeding risk does not increase that much. The ischemic risk goes down.
Right.
But Samir, but all of us, yeah, I think Hinamat sir would also agree, all of us are a little more comfortable in giving DAPT longer than adding this smaller dose. We have to get used to this new thing. Whenever you did left main stenting and complicated procedures, actually it might shift to clopidogrel and continue clopidogrel and aspirin longer. But we have to relearn ourselves and re-educate after this COMPASS data, where I think small dose aspirin and rivaroxaban, that's what is showing the better results. But many of us have the habit of continuing DAPT longer in Indian patients.
No, I think, Dr. Srinivas, we must make it clear to everybody at this stage that we are not giving rivaroxaban because we have a long length of stents.
Yes.
We have done a very complex procedure. It's not for that. It is to prevent repeat events which will come in future beyond 1 year from the unstented segments.
Yes.
So the stent protection, I think the DAPT has done its job for 1 year. And beyond 1 year, I think the incidence of stent thrombosis is extremely low.
Later generation is
really, yes, I think so many times I take off aspirin because trachegular alone has shown in so many cases that it's good enough to carry on. So this is for the unstented area. This is to prevent ACS coming from those sites. So if you have already shown on OCT that there are many areas which did not get a stent, but there are irregularities, there are subintimal depositions, I think it will help these areas by preventing clot formation.
I agree, sir. I think we need to learn and follow that practices and stay away from the routine habits which we have to give little DAPTs little longer, because we still have that cipher and taxus stent problems haunting us for some time. So I think that's how we are many times continuing DAPT longer. With later generation ones where I think single drug itself is working. Ticaplat itself is working.
Srinivas, now we are talking, today seem to be talking not just long duration DAPT, but in addition, trying to add an anticoagulant.
Low dose.
Yes. So I think it's a new concept. I think we are making our mental adjustment to this. And yes, I would probably feel, if you have a clear-cut lesion and you have stented them today, and if you have a young patient, like say 40 years, and you put a stent, are you going to give this rivaroxaban for another 40 years? That is a question. So I would probably not. So I would probably feel DAPT or even single antiplatelet is good enough to protect them.
I asked those investigators, sir, why did they use aspirin with 2.5 milligrams rivaroxaban? Why didn't they take clopidogrel 75 milligrams, which is supposed to be a little more better? Well, the answer, what he mentioned, investigator, was basically all of the patients were put on aspirin long term, not clopidogrel. That's how chance-wise they selected low-dose aspirin plus they knew Novak and smaller dose he was mentioning. But probably what I would be comfortable is probably using 75 milligrams of clopidogrel long-term and maybe 2.5. This is another new thing which I'm saying. I don't know whether it is proven or not. 2.5 milligrams of rivaroxaban long-term. Because aspirin, I think now all of us agree that it is producing troubles of complications, side effects, GI problems. So probably
also, Dr. Srinivas, we have enough data where aspirin with another antiplatelet and only antiplatelet. I think the data has shown that adding aspirin has not improved the results to a great extent.
Yes.
So obviously, we've been giving aspirin more as a traditional drug than we are buying a possibility of antiplatelet action. Samir, your comments, because I'm not sure whether you're going to be with us next time, but we'd like to have your wisdom comments.
I totally agree with what has been said. And Srinivas, the data is coming about clopidogrel with rivaroxaban. So we might see that strategy being adopted. Similarly, apixaban and clopidogrel data is also probably on the way. And giving rivaroxaban and aspirin, the DPI, for how long will always be a question. But I don't think that we can continue to give this DPI to the patients as they grow older and older, because their bleeding risk is going to increase as they grow older. So at some point of time, we'll have to decide that this is it, and this is where, after so many years, you switch back to single antiplatelet. Having said that,
I would feel once we are gone, say 3 years from the index event, our emphasis should be more on stabilizing the plaque. So I would probably move more strongly towards anti-lipid kind of therapies than antiplatelet kind of therapies.
Yeah, and as you very correctly pointed out, it's not the stent thrombosis we are worried about when we are prescribing DPI. In COMPASS trial, the reduced mortality came not from only stent thrombosis side, it came from further ischemic events and the stroke. Stroke reduction was very big with DPI.
Dr. Kuti, you have any comments? I don't know whether he's trying to talk.
No, nothing more. I think Dr. Samir has elaborately explained regarding that point of use of anticoagulation, the dual pathway inhibition, when it should be used, the limitations and the aspects which we should carefully evaluate and decide on whether it should be DAPT or a SAPT or a DPI. The only indication for a dual pathway inhibition was diabetes. A polyvascular disease, I will consider polyvascular disease or patients with renal dysfunction as the strongest indication, and also peripheral arterial disease.
Peripheral arteries, yes.
So there also the dose remains same, 2.5 twice a day?
Yes, sir. 2.5 twice a day.
The same COMPASS, sir. COMPASS trial only has all that. The peripheral vascular disease, strokes.
I know, almost 70%. Very striking reduction in the peripheral artery.
Yeah. Okay, I think Samir has to leave, he says, but I think time is up.
Yeah, we have completed all 2 cases, sir, for today's discussion.
Right.
What happened to the third case? You didn't invite a third case?
Sir, there was some slightly some miscommunication from our side, sir. I think so, because
if you have any such issue, I can promise that I am ready, Dr. Srinivas, Dr. Jabir, we are all ready with a case. So
yes, sir.
You can always fill in the third slot, not a problem.
Definitely, sir. But this time we could not have this third case, so we need to stop.
I
Maybe
think I thought he's
I'm
not
sorry.
mentioning-
Was I supposed to?
Yeah, that's
bring
what
the
he's
third
not
case?
mentioning. But what they
Oh,
plan.
I'm so sorry. I'm so sorry.
No.
Actually, Samir, this was the first time after 25 meetings that we thought we'll have two regular presenters and one somebody like you who have huge experience and we could learn from you. So I think that was the whole idea, but I think probably did not get conveyed to you. So,
I'm so sorry. I think.
no, we are sorry. We didn't. We just invited you as one of the top.
But we had good discussion, Samir. Thanks for joining.
Yeah, absolutely. But I'm actually not using rivaroxaban like this for later prevention. I think my strong emphasis is on statin, and I like to hit LDL of 20 and maybe under 20.
You started using PCSK and injections.
Yeah, plenty. I mean,
if you have to hit 20, you have to use it because only statins may not decrease it to 20.
No. So in fact, we counted PCSK9. We are writing at least one every day.
Okay.
Though I don't think everybody takes it. I mean, people talk to the agent and then half of them don't take it. But I think our thinking is very strong that later you go, I mean, 1 year and beyond, I think it should be more on lipids and not so much on antiplatelet.
Yes. Thank you.
Samir, special thanks for joining us today. We have this kind of discussion, and I hope you liked today's discussion too.
It was wonderful. It was wonderful.
And anyway,
it's always great to listen to you.
No, whenever you have free time, please let us know. We would like to get you in. I mean, I'm asking a very odd question, asking Samir free time. And, so that will never happen, but I think we will tell you that these are the meeting timings, and whichever one you can join, please join. I mean, it's always fun as well as learning whenever somebody like you is here on this forum. So special thanks to Dr. Samir Dani for joining us this evening.
Thank you.
Samir, how is the Navratri going on in Ahmedabad? Is there is the COVID restriction has affected the usual Navratri festivals?
Yes. COVID restriction is there, and the Navratri celebrations are with dampened. Yeah.
No Dandiya.
Not really public.
Okay.
Generally very small gatherings.
Okay.
So
thanks a lot. Thank
you
for everything, and it was fun. It was great being there. Thank you.
Thank you.
I did my MD in Gujarat, so it's so colorful Navratri.
Oh, that's why you're remembering your old friend.
In front of our hostel, it was a beautiful ground where they used to dance for 10 days. The whole 10 days, 9 days of Navratri, there were dances in the night. It goes up to late night. The Dandiya.
You should start in Kochi, this kind of.
Sir, in Pune, cases have come down now, sir. Now, no COVID, no? Not much COVID in Pune, no?
But they have definitely come down.
Yeah. Good, very good. Hyderabad, also, no, we don't see much now.
Hyderabad, there is no COVID at all, isn't it?
Very less. Hardly any. Right. Thank you.
In fact, my Ruby Hall has one main hub and they have 2 peripheral hospitals. So in the main, we have stopped taking COVID patients. So if they have COVID positive, we shift them to the 2 peripheral. And Dr. Onkar, over to you.
Yes. So Neha, you would like to go ahead?
No, sir. I would just say it's very nice to be back and meet Dr. Hiremat sir, Dr. Srinivas sir, and Dr. Jabir sir. September was little dry after 25th event. So I'm feeling happy to be back and listen to all 3 of you. And Dr. Srinivas sir, thank you for showing us the middle part today. I was just thinking, so Lord Buddha, there is a very famous saying, that when you don't find a solution, always think of the middle path. So 7,500 was exactly that middle path that you showed. So thank you so much. And over to you, sir, Dr. Omkar.
So thank you very much, sir. We are starting with this new forum and with this new format, and we will be bringing a lot of cases again with the senior faculty also joining this program. So our next program is after 15 days. So I will be in touch with you again with the details and all. So I thank our course director, Dr. M.S. Hiremat sir. I thank our moderator, Dr. Srinivas Kumar sir, Dr. Jabir sir, and Dr. Samir Dani sir for joining today. I also thank our faculty for tonight, Dr. Verma sir and Dr. Dedia sir for presenting two interesting cases. And I also thank you, Lord, thousands of audience attending this case. Just one
suggestion, sir. Hiremat sir, I have is we should make some form where we can take some comments or chat questions from the people who are attending. Now we are only 3-4, but if we can create some mechanism where some people who are watching the live streaming can send in chat questions, that would give more value. And
definitely
it is open, as I understand, Dr. Omkar. People can put their question on the chat box.
Yes, sir.
No, but they can't directly chat into our Zoom, sir. They are doing it in a different platform. I think some of them from the technical team has to post here.
Collate here, sir. Collate here. But sometimes the discussion goes so inquisitive. We don't want to disturb with this. So that's why
we can, somebody in the back end can keep collecting questions.
Yes,
in the end, we can answer, because we need to encourage some sort of feedback and questions, and probably clearing the doubts of people who are attending. That sort of thing also would be better. Just plan something, just throwing some.
Yes, sir. Definitely, sir. Right. Next time onward, we will definitely do it, sir.
Thank you.
We'll catch up after 15 days, sir, on a last Friday of this month. Happy Dashera and Navratri.
Yeah, happy Dashera to everybody.
Thank you.
Yes, sir.
Thank you, sir.
Good
Thank you.
night.
Thank
Good
you.
night. Good night, everyone.
Good night.